So our patients, I said, are at risk. We're seeing more and more patients who are overweight. They're immobile, unless, of course, you are trying to get them through the nice 083 guideline and have them intubated but awake and moving around. They have a hypercoagulable state. And traditionally, we're treating them with our ventilator care bundles, which includes slightly head-up tilt, interruption of sedation to get them to move a bit, and anticoagulant drugs, such as low-dose subcutaneous heparin. We try and use Flowtron pumps and compression stockings. Of course, in the trauma patients, this may not be possible. And more recently, especially if you get on well with your interventional radiologists, and luckily we do in Reading, we've started to use IVC, or inferior vena cava filters. The ventilator bundle, of course, is one of the 10 high-impact changes that were delivered to us by the NHS Modernisation Agency about 10 years ago. It's felt that if you use these bundles of care, that you should be able to, and for the ventilator bundle, it's DVT prophylaxis, peptic ulcer prophylaxis, prevention of ventilator-associated pneumonia, as well as managing sedation effectively, then we should be able to reduce the number of days spent in intensive care. They estimated up to 14,000 bed days per year saved by agreeing with the elements of the ventilator care bundle. So the drugs we know about, they can cause bleeding, they may make it difficult to do operations such as laparotomy or tracheostomy, and to get around this, recently some people started to take the patients down to the CT scanner or interventional radiology room and put in IVC filters. And the traditional filters are there to see, but you may be surprised or not surprised to know that in England or in the UK between 2012-2013, of the 1,323 filters placed, only 423 were removed. So are they retrievable? There's been a meta-analysis which looks at 6,800 patients. Only a third of these IVC filters were removed, and those that stay in are at danger of fracturing and being misplaced and actually migrating or perforating. So there are dangers of leaving these IVC filters in. The medical device alert issued by the MHRA in May this year has actually warned about this and actually says try and get these filters out as soon as possible. So what we're here to discuss today really is a novel approach to that, and I'm very pleased to welcome Professor Louis Engel. He's Professor of Medicine and Pulmonary and Critical Care at the University of Texas Health Science Center at San Antonio, Texas. Louis.
Pulmonary embolism is, as mentioned before by Carrie, is a very significant health problem. And it's a problem that, again, has been well recognized in the United States with the recommendations by the Surgeon General, and also here in the UK, where more than 25,000 patients are dying every year as a reason of pulmonary embolisms. And as you see here in the NICE guidelines, the focus that they have, where you can have the most significant effect with pulmonary embolism, is in the prevention of pulmonary embolisms that happen while you are in the hospital. So that was kind of the goal of this NICE guideline, was trying to decrease the risk of VTE and pulmonary embolism in patients who are in the hospital. As we know, this is a problem that has a large population at risk, and in particular the ICU patients, they have the highest risk in the hospital. It's very frequent, more than 360,000 cases of PE in the United States, again, close to 100,000 deaths because of this diagnosis. And both the NICE guidelines and in the US is recognized as the most common preventable cause of death in hospitals. The morbidity and the mortality is very high. It's very expensive, not just the treatment, it's just the diagnosis. When you suspect somebody in the ICU with this, trying to make the diagnosis, moving the patient to get the CT scan and diagnose this is complicated. And also, for us, clinically, it's very complicated. Many of the patients, they have no symptoms. They get hypotensive or hypoxemic on the middle of the night, and that may be just the first PE that they throw during the hospitalization. In some patients, the first manifestation may be a massive PE and sudden cardiac death. Even data from an autopsy report from Italy when they look into patients who died recently, up to 2011, in the ICUs, despite receiving prophylaxis with anticoagulation, still they find out up to 14% of those patients, they have some form of PE. It's not to say that everybody that died of PE, but it was a very common finding on patients dying in the ICU. And the problem is not going away. I think that we didn't diagnose many PEs before, and here is the period of time when we start using the CT-PE angiograms. So when these ones come, obviously, there's more than 3 million of these CT scans that are sent every year in the US on patients suspecting pulmonary embolism. We start finding a lot more PEs. So this is a problem that is not like it's getting a lot better. It doesn't mean that it's getting a lot worse. It means that we are diagnosing these pulmonary embolisms. And now this gives an incidence around close to 360,000 cases of pulmonary embolism in the United States. We are probably treating some of these patients better, and the mortality hasn't increased much. And also, we probably are detecting some PEs that are very small, that they don't have any significant increase in mortality. At the same time, we have been a lot more compliant with the guidelines of the use of anticoagulation. As a result of that, again, the mortality probably hasn't increased much, but we have paid a price for that with increase in complications with bleeding, including intracerebral hemorrhage or GI bleeding. So there is always a correlation in increase of anticoagulation with some of the increase of bleeding complications seen on these patients. One of the things with pulmonary embolism that is interesting, even if we as physicians are very aware of the risk of this problem, the community is not very aware of this. People is very familiar with the risk, again, of mortality with colon cancer, breast cancer, prostate cancer, car accidents, and even if you combine these three here, the mortality is still less than what you have with pulmonary embolism. The problem is that many of the patients who die with pulmonary embolism, the diagnosis of death is not a PE. They are frequently diagnosed with an intracerebral hemorrhage or it was a major trauma. So the final diagnosis is missed in that regard, and this community is thinking, oh, the patient died because of this major trauma that he has, but end up dying because of the pulmonary embolism. And if you look at the prophylactic measures or the preventive measures that we have, for example, with colonoscopies every year, we do in the US around 14 million colonoscopies every year. And if you do a colonoscopy in every American trying to prevent mortality from colon cancer, you can prevent around 1/3 of the deaths. It's around 18,000. If you do mammography in every female over 40 years for 20 years, in a total of probably like 1,500 mammograms, you can prevent 1 death with that, and you can prevent 8,000 deaths. If we are very active on trying to prevent deaths from pulmonary embolism, especially in our ICUs, we can have a significant impact that will be even higher than the impact that we can have trying to prevent colon and breast cancer. So I think that there is a lack of awareness in the community. We as physicians, we understand that, but in the community to say, hey, we really need to be active on this prevention of pulmonary embolisms. I'm going to spend too much time here. All of you are critical care physicians, so understand this, but the bottom line is there is a lot of patients who arrive in the ICUs in which, again, the risk of anticoagulation is significant. Patients with neurosurgery, spinal cord injuries, major or severe trauma, or some patients with PE that cannot receive anticoagulations. The risk of DVT is extremely high on those patients, and the complications with bleeding are catastrophic if you have these patients in the ICU developing a major bleeding for that. The major study that looks into critical care patients and prophylaxis is the PROTECT study. It's a very large study, over 3,000 patients in 67 ICUs in multiple countries, that start looking at patients who arrive into the ICUs and were able to receive prophylactic anticoagulation with unfractionated heparin or with deltaperin. And you can see they exclude so many of the patients that we are talking about, patients with trauma, neurosurgery, recent orthopedic surgery, or contraindications to heparin. So they exclude a lot of patients, and they have an ideal population that could receive anticoagulation. And from all the presentation and the message I want to give, I think that this is the most important area for us as critical care physicians, is to understand, first of all, they have like over 67 cases of pulmonary embolisms in patients on a clinical trial with a compliance over 98% on the heparin and low molecular weight treatment. Still pulmonary embolisms were present close to 2% of the population. So you think about the 5 million patients that we have in our ICUs, that means even with ideal anticoagulation, still you can have 100,000 cases of pulmonary embolism. So it's not universally effective, it's very effective, decreases your risk around 75% of developing a PE, but still you have pulmonary embolisms. And the second part that is really important on this message is that most of the pulmonary embolisms occurs in the first 10 days, with the peak being on day number 6. So it's a very common problem that the patient gets into the hospital and initially they develop the pulmonary embolism. It's not really here 2 or 3 months later. Different than other populations like the orthopedic patient that goes home, doesn't move, and develop the PE 3 or 4 weeks later. The critically ill patient, this is the point where they are developing the pulmonary embolism. So what options do we have? If anticoagulation cannot be given, or if it's given and it's not 100% effective, do we just say, okay, that's all we have, or do we have any other options? So we know that the pneumatic compressions, they really don't work very well in this population. They haven't been well studied. And the filters is one of the things that is used more commonly in the United States. It's not used very often here in Europe or in other regions of the world. So we have this systematic review when we look into these issues of the filters with a large number of patients. And we find out that the prophylactic indication is the most common reason why we use this filter in the United States. The rate of pulmonary embolism is low. Again, it's similar or lower than what you are seeing with anticoagulation. However, the insertion time in these studies was around day 7. So it's a little bit too late. There is a lot of PEs. You are missing around 70% of the PEs if you start inserting this on day 7. They retrieve only 34%, and this is in clinical studies designed to remove filters. And when they retrieve it too late. So all of those things are kind of not used on the right time for the right indication when you are trying to use a prophylactic filter. And they have a lot of complications too when you leave them. So you have that combination of a filter that is placed late, that is not removed, and that has a lot of complications. It's not a surprise that this environment around the filters generates this incredible controversy with the FDA saying, hey, we have to have a warning here. And also like Carl was saying a second ago, if you place this filter, they have to be removed and they have to be removed early. But it's not like the filters are not effective. Granted, they haven't been studied properly. You can see, again, this is a very recent study published in the JAMA Network in the surgery series from 2013. And the bottom line here is they are looking at the incidence of PE in patients with major trauma in 6 different clinical trials. And they see, again, when they do the meta-analysis of this, that the rate of pulmonary embolism is decreased when you use filters. The same thing when you are looking actually at sudden death on patients with trauma, with pulmonary embolism. The effect, again, the statistics is not very strong, but still the effect is significant decrease in this. So that part of the filters being effective on preventing major clots from going from lower extremities into their lungs and pulmonary embolism, at least in this systematic review, shows that it's effective too. Here is another point to show it the filters may be effective, and this is probably more compelling because you are looking at patients who already have a pulmonary embolism, and the classical teaching is usually you survive your first PE, you may survive this with no problem, but the next one, if you have a second PE, is the one that is going to get you into a lot of trouble or that's going to kill you. So they look here into a lot of different populations. The red groups are the patients with the filters, the blue is with no filters, and they say you have a pulmonary embolism, it's probably a small PE, you are stable. The filter really doesn't have a significant impact on changing your mortality. However, if you have a very large PE, even if you are stable, or you are unstable requiring thrombolytics, there is a very significant difference. Again, in mortality here with no IBC filters on red, there is a significant change in the mortality here when you are seeing in patients with no filters versus the filters. So that's what we have. That's what we were trying to do, is trying to provide a way to give prophylaxis to the patients that it can be given very early, or as soon as the patient arrives into the intensive care unit, it can be removed in all the cases, and also give the additional protection or the additional value of having a central venous catheter. So trying to incorporate the use of the IVC filters in a procedure that is commonly done. This is some of the experience that we have in the original study that we did for this filter. I'm not going to spend too much time because that's the rest of the lecture when you are going to have some of the UK cases. But this is one of our patients, 7 in our study, that by day 8, when they were going to remove the filter, the patient has a very large clot and prevented a significant pulmonary embolism. And then again, you can see when they were going to place another filter, remove our device, and a few weeks later, they removed the other filter with no pulmonary embolism. So we know that we can be very effective on preventing these events. And what I'm here also is to learn about the experience that you have been having here in the UK. Thank you so much.
Hi, thanks for inviting me to speak. I am from the Royal London. We're very keen on succession planning at the Royal London, so you can see I was advertised as the Clinical Director of Trauma. Unfortunately, the real Clinical Director is actually also on the programme, so I better just make it clear that I'm not that person. I'm going to talk about VTE prophylaxis in major trauma and how we do that at Barts Health. This is the new Royal London building, and it's where one of the 4 major trauma centres in London, and also home to the air ambulance, which brings quite a lot of business my way. Venous thromboembolism is widely reported in the literature for trauma patients, but the rates vary very significantly, and they vary by country and even within countries, and certainly in terms of the environments in which these patients come from. There's a lot of military work that goes on in trauma, and some of those rates are reported there. So you can see the wide variation from 1.8 to 44%. And the problem is that it's very difficult to standardise your trauma patient. There's a wide variety of different traumatic injuries included there, from your walking wounded to your code red, very significantly injured patient. And the ICS scores also vary very significantly between those studies. It's a little difficult to interpret a range of 1.8 to 44%. The other problem that we've touched on already is that observational bias also impacts quite significantly. We don't really know what it means if we go looking in every patient to see whether they've got a DVT or even a PE. We don't know whether that's significant, whether those asymptomatic clots are significant, and are we identifying more patients that certainly have this disease and not affecting the mortality, and that certainly seems to be borne out by the data. However, having said that, we don't have a lot to offer these patients in terms of primary prevention of venous thromboembolism. Quite often, TED stockings are contraindicated because of extremity injury, and the same would go for pneumatic calf compression. Pharmacological injury is often a no-no if you've got very significant neurosurgical problems, if you've got spinal injury, if you've got a big chest injury, you're very prone to bleeding. Anything in the abdomen often bleeds significantly, and pelvises. We see a lot of pelvis injuries, and we quite often will not be able to pharmacologically treat those for venous thromboembolism. What's the risk if you get a DVT? Well, 3.2% in one series of DVTs are complicated by a PE, and we know that in trauma, if you get a PE, your case fatality rate is somewhere between 25 and 50%. Now, okay, we have another big range of percentages there, but I think we can say that that's a bit worrying, that if you get a DVT following major trauma that then get a PE, a quarter to a half of those patients will not get out of your unit. It is the third commonest cause of death in trauma patients who survive more than 24 hours, and that follows bleeding and infection. It's definitely a reasonable problem, and I'm sure anybody who's looked after major trauma patients will agree that you see patients who certainly develop PE in the context of big injuries, and it's very difficult to tease out exactly what the ultimate cause of death is, but I'm pretty convinced that PE plays a role there. Now, we know, we've all heard about the anticoagulation of trauma that occurs very early on and is multifactorial, but there's also a procoagulopathy of trauma, and this occurs for several complex reasons. We know that there's a pro-inflammatory state that can often occur as early as 6 hours after the injury. We've certainly got some data from the Royal London, from Karen Brohy's group, that looks at TEG and actually looks at ROTEM and looks at the coagulation profiles of our trauma patients, and we very quickly see that the anticoagulation of trauma is reversed, and we see significant procoagulopathy certainly within the first 48 hours, if not earlier than that in some patients. We know there's pro-inflammation, we know DIC occurs, there's tissue factor and thrombin generation problems, all of which go to provide this procoagulant state. Plus, there's ourselves. We are very active in giving blood products. Certainly the ratios for trauma of 1 to 1 to 1 mean that we're giving a lot more product than perhaps we did in the past. And that forces us down a procoagulant state within 24 to 48 hours. This is data from our unit looking at the timing of VTE after major trauma, and it pretty much coincides with what Professor Angel said, in that the majority of these occurring early in the stay. Certainly around, there's a peak between 6 and 10 days, and then a secondary peak around day 20, and then the odd 1 or 2 later on. So the question really is, what are we going to do for this guy? This is a chap who was assaulted somewhere in deepest, darkest Kent, was flown into the Royal London, and clearly has a very significant head injury. Now, I don't think that anybody, whether you do major trauma or not, is going to want to prophylactically anticoagulate this guy. Yes, you can put stockings on, yes, you can do mechanical prophylaxis, but it's unclear whether that's going to cover him significantly for his risk of VTE. So in that context of isolated head injuries, just to take one group of patients, is pharmacological prophylaxis safe? Well, if you look at the literature, it's a little bit confusing. In fact, it's very confusing. So this is a paper from the Eastern Trauma Group in the US. They say that it's perfectly safe. After 48 hours, if you do serial CT heads, so you do a CT head every day, if you see no increase in the hematoma size or the contusion size from one day to the next, then you should start to use pharmacological prophylaxis. Well, that's quite interesting, because if you go to the opposite side of the US, the West Coast say, no, it's completely unsafe. They looked back at all their patients. They divided them into those who had received pharmacological prophylaxis and those of them who hadn't, and looked at the increase in contusion size or hematoma size. And they saw that if you received heparin, or a low molecular weight heparin, 40% of the patients who received it increased their hematoma size. Only 22 if you hadn't received heparin. So there's a significant difference between those receiving heparin and those not for increase in hematoma size. And that's about all there is in the literature about whether it's safe in terms of isolated head injury patients to give these, give pharmacological prophylaxis. And there's certainly nothing about what sort of prophylaxis you should be giving. So what options do we actually have? Well, we know that there are plenty of guidance out there. So this is the NICE guidance for VTE. And this is the flowchart that's in that guidance for major trauma. And it's not very helpful. So it's not really helpful for the patients who have major trauma and bleed and are at significant risk of bleeding. Yes, we should put mechanical devices on if we can get them on. And yes, we should do an assessment for bleeding. But it doesn't really say what to do if you can't give heparin. So if you go to the US and look at the ACCP guidance, this is, I think this was updated in 2012. This is not for major trauma, this is for orthopedic guidance, orthopedic operations. We do know that if you give the blue line, if you give no prophylaxis at all, you've got a pretty significant rate of VTE. If you give some, which is the green and the dotted red line, for either an early stage or an extended stage, then you will find that you will get some protection from giving pharmacological prophylaxis. So they advise pharmacological prophylaxis, but if you're assessed as a high bleeding risk, they also suggest that you shouldn't have an IVC filter. Now, this was based on a meta-analysis that was done just at the end of 2009, I think, and they've based this data on lots of historical papers. There was only one paper in that meta-analysis from the year 2000. Didn't have many patients in. There are not many papers that have good numbers. This advice is also based on 3 studies in that meta-analysis from 1950. Now, that's just a little bit before I was born, and I hope medicine has moved on slightly. So what did we do? Well, we thought we needed to write something as a policy of how we were going to approach prophylaxis in these patients. And absolutely, we would be using TEDs. We would also be using Clexane as our low molecular weight heparin of choice in those who we felt that was appropriate. However, we also wanted to write in that we would use an IVC filter to cover patients who we felt were at the highest risk, both of developing venous thromboembolism, but also of bleeding if heparin was used. And these are really patients. This was driven by the orthopedic surgeons who had, anecdotally, 3 deaths on the table, all of whom were having ORIFs of major pelvic injuries, who hadn't received Clexane for the risk of bleeding from those injuries. And they'd spent 4 or 5 days on the ward waiting for surgery, and then gone to theatre and arrested under anaesthesia. They now have if those patients miss 48 hours of low molecular weight heparin, they insist on an IVC filter placement prior to those patients going to theatre. The other patients who are obvious in this group are isolated head injuries with major contusional injury, spinal injuries, and several bony injuries to the extremities, especially femur, tibia, especially if you've got more than 1 fracture. The problem comes down here, that we want to get this is short-term risk. We need to cover these patients for a short period of time when they're going to be most exposed to developing clot, and that's going to be early in we know that's either going to be early in their stay or around day 20. Now, hopefully, by day 20, pretty much whatever their injury, barring the odd 1 or 2, we should have been able to institute some kind of pharmacological prophylaxis on a heparin-based drug. But how do we cover those patients at day 4, 5, and 6 who we want to get into theatre early, but who we don't want to put filters in? And we don't want to put the retrievable filters in because we don't take them out. Now, we know that looking back at the ones that we've done in the UK, only 34%, I think it was, 34% of those are retrieved. Now, I suspect there's a reasonable number of the patients in the non-retrieved group who've died with them in, but there's also quite a significant number of people wandering around with what are now permanent IVC filters. We don't really know what to do with those patients. Should they be on lifelong anticoagulation? Well, the answer is probably yes. Do they have a significant increase in their DVT risk? The answer is definitely. Do they have significant problems with device failure down the line at 4, 5, 6 years? The answer is probably yes as well. And that's despite fairly good improvements in the devices themselves. So this is a group in the US showing that this is possible, that we can put IVC filters in these guys to cover their short-term risk. They did not look at the removal either. So it's, again, we're still having problems tracking these patients down and getting these filters out. And these are the risks. And if anybody who's looked after patients who are involved in trauma, it's often the mad, bad, and the sad. and they're a notoriously difficult group to follow up. They tend not to be very keen on turning up to clinic, and they often come from a very disparate area. They're not necessarily your local population. They're often from far and wide and get shipped in by helicopter. Probably more so in other countries, but we're seeing it more and more in the UK as well. We have difficulty tracking them down, especially once you've let them go out of the hospital. So it was felt, certainly at the Royal London, that this gap could be filled by the angle catheter. And it gives you the added bonus of a few more access to for your central venous access. So you've got 3 ports and the IVC filter, and it's all attached. So there's no retrieving this. When you deploy the device, you use it for 10, 12 days, however long you want to use it for, to cover that short-term risk, and then you resheath the device and retrieve the catheter. And that's it. You don't have to worry about that long-term risk. And it takes out many of the risks that we've just discussed in terms of longer-term, potentially what we'd call retrievable, but actually permanent IVC filters. And this is an abdo X-ray of our second patient. This is a chap who fell a considerable height off some scaffolding or a ladder, I think. And he'd got a primarily isolated head injury. And this was he did not have a mass lesion, so he didn't have a subdural or a extradural to evacuate. He had significant multifocal contusional injury. They are probably the most difficult group to pharmacologically give prophylaxis to, because there's nothing you can do surgically. If you've got an extradural, you can hoover out the clot, re-CT in a couple of days, and if nothing's reaccumulated, you might be able to start prophylaxis around day 4. Bad contusional injury, especially multifocal contusional injury, you may be a little bit more reluctant to do that, and they certainly have bleeding risk up until day 8, 9, or 10. Now, we deployed the device. I don't know whether it projects very well, but it's somewhere here, I think. Maybe a little bit higher. I can't see it at all. Yeah, there's a white dot there, and the device is deployed in the IVC parallel to the spinous process. That device stayed in for 8 days. Unfortunately, the patient only survived 8 days, so we retrieved this one post-mortem, nothing to do with the catheter. And we retrieved it with no clotting. So once we took that catheter out, there was no clot in the device. This is an interesting lady who came over from France and arrived off Eurostar and looked in the wrong direction and stepped in front of a black cab. She had a very significant liver laceration, which we partially managed with interventional radiology and some embolization, but only partially. And she still was clearly still bleeding a little bit, but not enough to warrant going to theatre and having a full laparotomy. So we were sort of crossing our fingers, hoping that everything would just sort itself out, but clearly didn't want to anticoagulate her. She's interesting because we knew we weren't going to anticoagulate this girl anytime soon, so the device was deployed very early in her stay. She also had a fairly significant thoracic spine injury as well, which was added reason not to anticoagulate. So we deployed the device within 36 hours in this girl, which is reasonably quick, and we'd like to deploy it quicker than that in the future. But she also had some contrast that remained in her kidney and her renal pelvis, and you can see the device is deployed above there, and we saw no ill effects from the deployment at that level. We took that device out, no clot in it, and it seemed to work without a problem. Now this is a little, to remove the devices, we're doing a venogram to check if there's clot in the device. Now you can see here, this is actually a traditional retrievable IVC filter that's been placed, because when we did the venogram, we saw significant clot in the Angel catheter, in the deployed filter. So the choice is then, don't do anything, don't take anything out, just go back to the ward, heparinize on a more significant dose of heparin, and then go back to do a venogram in 48 hours. Or, as in this case, this is a chap who had significant traumatic chest and head injuries, but had also had a previous history of PE. So we knew this guy was at significant risk. we deployed a traditional filter above the angle catheter and then took the angle catheter out. And you can see that's the clot that we retrieved from the catheter, from the filter itself. This is not one of mine, unfortunately. I'd love to get this sort of image, but this is some colleagues in Poland who you can see are looking after a gentleman with significant pelvic trauma. He's got an external fixator on, and the catheter is deployed nicely in the IVC, protecting what must be very high risk of VTE for this multiple injured patient. And that's it, really. That's all I've got to say in terms of VTE prophylaxis in trauma. And we have so far put 9 catheters in, 8 catheters, and I think we've just done another one this weekend. And 7 of those are in major trauma patients and 1 in a medical patient with a PR bleed. We've so far had no complications that we can directly attribute to the device. And it seems to be filling that gap for us for covering short-term risk. Thanks.
Okay, just to finish with, just tell you a bit about our experience in Reading at the Royal Berkshire Hospital. And we have put in 8 to date. The Royal Berkshire Hospital isn't as grand as the London Hospital. The nice bit of the hospital at the front is being, there's a possibility we'll lose that to a local school, which would be a shame, but such are the hard times we're going through. The new block down the side, you've got a nice picture of the admin offices, brand new. We're in the south block, which isn't so new, but we've got a great team. We were 11 beds, we're now 17 beds with an outreach team as well as a comprehensive outpatient follow-up clinic. And how did we choose which patients to put them? Basically, you've heard some of the indications. Those patients who are actively bleeding, those patients who require major surgery or tracheostomy, and we see this as a short-term way of preventing pulmonary embolus in those patients we feel would be at risk. The Angel catheters we first used sometime, I think it was about April this year, and it was first mentioned at this meeting at a lunchtime session exactly a year ago. We agreed to be involved in the initial European Union trial. We have a safety team at the Royal Berkshire Hospital, and this was seen as one of the chief areas of improvement, thromboprophylaxis, so it seemed a win-win situation and a good topic for quality improvement and addressed an unmet need. The main thing about it, as I can see it, is everyone would think putting IVC filters in is the preserve of the radiologist, but luckily, as I've already mentioned, we got on very well with the radiologists, and between us we agreed to trial these new devices. So those patients at prolonged risk, where there's risk associated with the use of anticoagulants, and that was our very first patient. She was 80 years old, a lovely lady with our research nurse, Ellen, and it's an easy device to use, but very important you do have guidance and education. You can't just be left with this to put it in, you must have the training. You can do it in the intensive care unit, don't have to go down to the radiology department, and you don't need to call out an interventional radiologist who may not be available that particular night anyway. So you don't need to do it in the presence of a radiologist, but you do need to use radiology at the time you want to take them out, which is easy to predict. Have hydrophilic coating, they're easy to put in, and we've had just one problem in the, we've actually tried it 9 times, used it 8 successfully, and 1 we couldn't actually locate on X-ray, which was that particular case there. The first case I showed you, so we had a mixture of trauma patients and those requiring major surgery who we felt were at risk of pulmonary embolus that we couldn't anticoagulate. So those are the cases we've used to date. The case that we couldn't locate, the basket, I don't know if you can see the stem, but you can't see the basket. We had 3 radiologists look at it. We couldn't see it, but we've addressed that problem by agreeing what sort of exposure of an X-ray we're supposed to put in to be successful. So while the catheter's in place, We don't need to anticoagulate them, so they can have their tracheostomy, they can have their surgery. When we feel the surgery has been successful and there's no risk of bleeding, we can restart anticoagulation, and then a day or so after that we can then arrange for a venogram in radiology and take the catheter out. So there was our first case, that nice lady you saw. This was written up in the handout you have by Andy Warden and the team that were on that night with him. This is a patient that came with rectal bleeding, required a Hartmann's procedure, and therefore we felt anticoagulation would be inappropriate with her bleeding, and she had an angle catheter which was successfully placed and removed 3 days post-operatively. So that was our very first case. I think it was the first case in Europe. And that even made the Arab Emirates top news somehow. I don't know how it got to there, but there you are. And a second case that I want to present was a polytrauma, a person that had been in the hospital 6 weeks and had worsening respiratory function, which is why he came to intensive care. So we were faced with someone that needed a femoral fracture that needed repairing, and he already had pulmonary emboli diagnosed by CTPA. And as mentioned earlier, we thought the risk of him having another PE would be so great. So we couldn't go to theatre with him anticoagulated. We stopped the anticoagulation, put in one of the Engel catheters, which was taken out 4 days post-operatively, by which time we'd restarted his anticoagulation, and he left ITU successfully. As I've already mentioned, and you can see, we've got a handout which was arrived today, hot off the press, to go with your next JICS. And remember, it does need education, so you need to be prepared. You can't just put this catheter in without training. That's the first thing I would say. Secondly, you do need to get on with your interventional radiologists and work as a team. It is a safety quality improvement project, and you're getting 2 technologies for the price of 1.
Thank you very much. My name is Alejandro Barrios from Birmingham. It's for Professor Angel. The 2 questions. One is the venogram. Can it be done through one of the access ports of the catheter? And the second question is, in your experience, what's the longest duration you've left a catheter in? Are they cervical? What are the concerns in terms of localized infection because they're being inserted at the groin site?
Okay. Thank you so much for your question. So there is 2 questions. The first one is if we can do the cavogram through our catheter port. Absolutely correct. The catheter is designed in a way with the side sheath of the catheter is located in a position that you can do the cavograms. The images that you saw on those cavograms were obtained through the catheter. So they don't need to have a second incision. And we are actually working on getting these cavograms bedside too, just coordinating the image with the X-ray. We minimize the transportation of the patient to radiology. The second part of the question is how long to keep the catheter and how it's been the longest. So that case that you saw from Poland, you understand that the catheter remained close to 20 days on a patient. Obviously, the longer that the patient keeps the catheter, the higher the incidence of infections. However, the risk of central line infections with short-term catheters in the femoral position consistently in 2 meta-analyses, one from the Cochrane and another from Marik, and more importantly in a recent study that looked over 1,400 catheters left in an average of 5 to 6 days on the femoral position. With the bundles that we are using now for prevention of infections, the rate of catheter-related infections was 0.2 for 1,000 catheters. So we have over 48 or 49 cases already. We so far have 0 catheter-related infections, 0 thrombosis related to the catheter at this point. Obviously, the experience is just growing, but we have been lucky on that regard.